In this following video, I'd like to discuss with you the challenges faced in dealing with a hard cataract whilst performing phacoemulsification. Now here's a patient presented with a grade 4 nuclear sclerosis in a well-dilated pupil. The plan for this patient was phacoemulsification with the implantation of a multifocal toric IOL. Having completed the preoperative markings on the slit lamp, we took up the patient for surgery under a peripalpal block. We start the surgery from the point of the capsular rhexis. I aim to perform an oval rhexis. It allows for ease of nucleus management as well as ease of IOL implantation. Let's see how we do it. So in order to create an oval rhexis, my initial nick is from the center to the 12 o'clock position, after which I then drag the flap upwards and complete the rhexis as demonstrated. Prior to performing a hydrodissection, I decompress the anterior chamber to reduce the anterior chamber volume to allow for a safe hydrodissection. In a hard cataract, there's always a potential of a posterior capsular blowout. So therefore, reducing the anterior chamber volume coupled with an adequately sized rhexis allows for a safe hydrodissection. Introduction of a dispersive viscoelastic is also equally important because it allows the corneal endothelium to be protected from the excessive energy that is likely to be required in dealing with these hard cataracts. I plan to perform a direct vertical chop, and therefore an adequate exposure of the phaco tip coupled with a long chopper is mandatory. Let's start with the direct chop. I impale the tip proximally. I go down well into the depth of the nucleus at the point of the center of the nucleus, after which, and having got to the right depth, the long chopper is impaled into the nucleus, and then both the instruments are moved apart, resulting in the primary chop. But as you can notice, the posterior plate at this point is still attached. At this point, I now choose to break down the heminuclei thus created into smaller fragments. Being a harder cataract, I'm not just going to make 2 fragments out of each heminucleus, but multiple, often 3, and sometimes even 4. You will notice that whilst dividing the nuclei, in some of the fragments I'm able to create a complete split, but in many of them, the posterior plate still seems to be attached. At this point, the second heminucleus, which is a lot smaller than the first one, is broken down into 2 fragments. In this case, you can see I've been able to create a divide right through and through the posterior plate. As you will see, I further divide this large fragment thus created into a smaller emulsifiable fragment. Being a very large dense nucleus, it's sometimes difficult to ascertain the extent of separation at the level of the posterior plate. I'm now going to proceed to the fragment emulsification. In this step, you'll notice how I've impaled into the nucleus at a greater depth, and I'm attempting to separate the posterior plate of the fragments in an attempt to perform a multi-layered chop. In order to perform a safe fragment emulsification, I replace the long chopper with a Sinskey hook. Now turn by turn, I impale the fragments and attempt to bring it up to emulsify it, but I can see that there's an attachment at the area of the posterior plate. So in order to overcome this, what I need to do is hold on to this fragment which is still attached, bring it up, downsize it, and then each of the downsized parts are held, drawn up and emulsified. In view of the fact that excessive energy is going to be required to emulsify this nucleus, an intermittent injection of viscoelastic is imperative. Let's now proceed to see how we manage to remove these fragments which are still attached. So turn by turn, as I described earlier, each fragment is drawn up into the pupillary safe zone, broken down further, downsized and emulsified. The posterior-most part of it still remains attached. Having realized that a significant part of the posterior plate is still attached, I had 2 options. One, I could go back in there in the sculpt mode and sculpt right through the center, getting to the depth and breaking down the nucleus prior to the emulsification. The other option is what I chose to do here. Note how with my phaco tip, I hold on to the posterior plate, elevate it a bit, downsize it, thereby severing the attachments within the fragments. Following the reintroduction of some more dispersive viscoelastic, I now deal with the rest of the nucleus. The rest of the nucleus is now rotated to come to the inferior position to allow for ease of emulsification. This fragment is now held, drawn up, further downsized, and you can see it still remains attached. And therefore now, to facilitate the ease of emulsification of the rest of the nucleus, I emulsify this central core to try and break down the adhesions between the two fragments, after which you can see with ease the rest of the nuclear fragments are emulsified. With this, we come to the end of the nucleus emulsification. Under viscoelastic cover, I now proceed to perform the bimanual irrigation aspiration. In this part of the video, you will see how with care and caution the entire cortex is removed circumferentially. Following the completion of the cortex wash, we then proceed to the introduction of the multifocal toric IOL within the capsular bag. Having completed the introduction of the IOL in the bag, with care and caution, the excessive viscoelastic is removed from in and around the IOL and in the anterior chamber, as well as the IOL is then oriented to attain its perfect position. This is what you will see in this part of the video. And I'd like you to notice that when the first and the third Purkinje images are overlapping over each other, both superimposed images are in the center of the IOL, as well as the toric markings on the IOL correspond to the markings on the cornea. This implies an optimal centration of this toric multifocal IOL. And following the completion of the visco wash, whilst still maintaining the irrigation in the eye, the paracentesis in the main incisions are hydrated. And finally, the irrigation removed from the eye and the right paracentesis incision also hydrated, and thereby bringing us to the end of this surgery. So in conclusion, dealing with a hard cataract comes with significant challenges. The greatest challenges, however, come in the nucleus disassembly. And I've discussed the strategies in managing the posterior plate in this particular case. The initial steps need to be performed meticulously and with precision. Adequate viscoelastic to protect the corneal endothelium, clear visibility down to the level of the posterior plate, and using the optimal strategies, either sculpting all the way down to the posterior plate with a mechanical divide, or a multi-layered chop, or dealing with the posterior plate, downsizing and emulsifying the posterior plate, followed by the emulsification of the fragments, seem to be the strategies that work in these very dense cataracts with the very tough and difficult to separate posterior plate issues. I hope you found this video tutorial useful. Thank you.